Video, we see a psychiatrist interview Vera, a Canadian patient suffering from simple schizophrenia in the 1950s. The psychiatrist's name is Dr. Heinz Lehmann. He recorded this and other interviews as training aids for doctors. Dr. Lehmann received his medical degree from the University of Berlin in 1935 before fleeing Nazi Germany for Canada in 1937. In the 1950s, he proved that the drug chlorpromazine could treat schizophrenia and that imipramine could treat depression. In the 1970s, he advocated for the legalizing of marijuana and research into the use of the active ingredient of psilocybin to treat anxiety. He was involved in removing homosexuality as a diagnosable psychiatric illness from the DSM, the Diagnostic and Statistical Manual of Mental Disorders. Simple schizophrenia is an interesting diagnosis as it is about to disappear from common psychiatric usage. In psychiatry, we generally use two different methods for classifying diseases. The United States mostly uses the DSM-5, the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders. The rest of the world primarily uses the ICD-10 or 11, the International Classification of Diseases, which is maintained by the World Health Organization. Simple schizophrenia was in the DSM-1 and 2, but was removed from later editions as a formal diagnosis. It was retained in the DSM-4 under the research category of simple deteriorative disorder. In order to be diagnosed with simple schizophrenia under the ICD criteria, the patient must have slowly progressive development over a period of at least 1 year of all three of the following. A. Significant and consistent change in personal behavior, showing as a loss of motivation, interests, drive, and social withdrawal. B. Growing apathy, underactivity, decreased speech and initiative, decreased facial expressions and nonverbal communication. C. Decreased social, scholastic, and occupational performance. And the symptoms cannot be better explained by another psychiatric or medical illness. With the new edition of the ICD, the ICD-11, which came into force on 1st January 2022, simple schizophrenia has been removed as a diagnosis and would simply be diagnosed as schizophrenia. We will use the ICD diagnostic criteria as our yardstick for assessing the patient. When I assess my patients, I assess them using a three-channel methodology. These three channels are the verbal, paraverbal, and nonverbal, and comprise 1. The verbal channel, what they say, the content of their speech. 2. The paraverbal channel, how they say it, the nature of their speech. 3. The nonverbal channel, what their body is communicating, their body language. I monitor all three channels for information and continuously check each channel against the others to ensure that they're all in agreement. If one channel is communicating something which doesn't align with the others, then the likelihood that a mental health issue is present or the patient is lying increases. The greater the difference between the channels, the greater the likelihood that the patient is lying or suffering from a significant mental health issue. Doctors in training and many of the various YouTube videos analyzing psychiatric interviews or police interrogations fall into the trap of stating definitively that a certain statement, tone, body movement, or posture proves X and only X. In reality, human communication is extremely complex, individualized, and dependent on the context. Drawing definitive conclusions from one communication channel without reference to the others inevitably leads to errors. The person being interviewed must be viewed holistically and within the context of their current situation. For example, two individuals may have the same nonverbal behavior, but given their different personalities, cultural and social backgrounds, the current circumstances they find themselves in, as well as their previous behavioral baseline, this nonverbal behavior may have two entirely different explanations. To jump to conclusions is to risk doing patients a disservice or, in the case of interrogations, accusing the wrong suspect. Abnormalities of eye movement and gaze direction are common in many psychiatric illnesses. Schizophrenia is no exception, with gaze tracking software showing promise as a diagnostic tool. For this reason, I'm going to talk a lot about eye contact in this video. Therefore, it will be useful to explain some of the basics of how to assess gaze. When speaking, Europeans and North Americans tend to maintain eye contact for approximately 50% of the time. When listening, they maintain eye contact for approximately 70% of the time. Less tends to be a sign of disinterest and will be noticed by the speaker. This is, of course, modified by social and cultural norms. These differences must be taken into account when assessing patients from different social and cultural backgrounds. Eye contact duration shouldn't normally exceed 4 to 5 seconds. The majority of people are most comfortable with 2 to 5 second duration, with the range being 1 to 9 seconds. The longer the eye contact, the more likely it is to be described as intense and uncomfortable. Eye contact accompanied by pupillary dilation of 5 to 7 seconds frequently signals attraction. Anything over 9 seconds is almost universally viewed as challenging and threatening. If you enjoyed this video so far and want to let me know you want to see more videos like this, please hit the like button. So, now that we've established the baseline for fully appreciating what we're about to see, let's start.
Deteriorate as time goes on. There's a characteristic lack of interest in the environment, withdrawal from contact with others, and with it goes an increasing loss of emotional response. These people become vague and empty. Their manner is childish and they are gawky. They show little or no initiative and spontaneity. If they do react emotionally, their reaction is often inappropriate. They have, of course, no real plans for the future. In spite of this general impoverishment of their personality, many of their intellectual functions remain intact. Memory and orientation are not impaired. The patient we are going to see is about 40. She has been sick for more than 10 years, lives quietly in the hospital, doing simple work in the laundry. She seldom speaks unless spoken to, and does not mix with the other patients. But she is really quite contented, and her lack of energy and animation is not due to depression and despondency, but to apathy. She might, during the interview, demonstrate inappropriate emotional reaction, particularly smiling or laughing when discussing serious subjects. She complains of auditory hallucinations, voices, and strange feelings of being controlled by unseen forces, though these are not especially common symptoms in the simple type of schizophrenia.
Dr. Lehman is establishing the criteria for diagnosing simple schizophrenia here. He is relating Vera's background, which establishes a prolonged period of illness with onset at roughly 30 years of age. He also describes a history which shows loss of drive and interests, aimlessness, self-absorbed attitude, social withdrawal, apathy, passivity, hallucinations, and lack of initiative. It is implied that this is a significant decline for Vera. Dr. Lehman also specifies that he has outruled depression as a factor for these signs and symptoms.
And how long have you been here?
I think that'd be 14 months in December, beginning of December.
In this place?
Yes.
You like it here?
Yes, I like it when it's quiet.
In terms of appearance, Vera is of normal weight, dressed simply and appropriately for the interview. Due to the low video resolution, I can't be certain, but it looks like there is a stain on her dress on the right side of her chest. If true, this demonstrates a certain apathy regarding her appearance. She is Caucasian and her hair is mildly unkempt. She is not exhibiting any involuntary or grossly inappropriate movements. She is fidgeting, but it is within norms. There are no obvious signs of physical illness. In terms of her behavior, she has poor eye contact, is sitting slouched in the chair, is withdrawn, and appears somewhat anxious. She is coping with her anxiety via the self-soothing behavior of fidgeting. There is no evidence of disinhibition in her behavior. It is clear that Dr. Lehman and Vera know each other well. I presume he was her treating consultant psychiatrist, and so they would have met once or twice weekly for the 14 months since her admission. Some rapport is present, although it is not excellent. If Dr. Lehman was completely unknown to her, it is likely she would be far more reticent to speak and withdrawn. To me, it seems she has a vaguely perplexed look on her face. This is common in patients who are psychotic. Her speech is low in volume and rate is on the slow side of normal, but still within normal bounds. Her rhythm is normal, but tone, the amount of inflection in her voice, appears restricted. Her latency, the delay between asking a question and answering it, is normal. This is important, as changes in latency are often an important indicator of stress and untruthfulness. Thought appears, so far, to be normal. In a psychiatric interview, we assess the content of patients' thoughts, the form of these thoughts, and any disorders of thought. We assess this by listening to what is said and determining what that implies about thought content, form, and function. It is very difficult and requires years of experience before subtler signs can be discerned.
You like it when it's quiet?
I find it too noisy, all those patients.
Sometimes it's noisy here because of the other patients.
Probably.
Note the low volume and poor eye contact. She isn't engaging emotionally with this point. She is non-verbally signaling a desire not to discuss something she dislikes.
How do you like it better when it's quiet? Have you always liked it quiet, or?
Raising the issue of noise made Vera agitated. She expressed this through increased fidgeting, shifting in the chair, and avoidance of eye contact. As Dr. Lehman presses her further on the topic, she lapses into silence and averts her gaze. Her verbal, paraverbal, and non-verbal channels are in perfect concordance. All are, essentially, screaming, "Stop asking me about this."
I've been used to living where it's quiet, except for the railway.
You told me once that you didn't like the radio.
Yes.
In the hospital.
I was unhappy when they brought the radio.
Why?
The ward was quieter without it.
Well, if you're very quiet, what are you doing?
Dr. Lehman is a determined man, and he presses Vera about the noise again. He phrases questions about noise as being about her preferences for quiet. Often, if someone doesn't want to discuss a certain topic, you can get them to open up by rephrasing the issue and approaching it indirectly. In this case, don't ask about her dislike of noise. Ask about her liking of silence. There is a marked lack of eye contact again. I counted 2 episodes of eye contact lasting 1 second and 1 episode of eye contact lasting 2 seconds. We haven't seen a single episode of eye contact reaching the 3-second threshold yet. Again, when asked a question she is uncomfortable with, her verbal, paraverbal, and non-verbal channels all align to say stop. Despite a 4-second pause she is invited to speak into, she maintains her silence, avoids any eye contact whatsoever, and fidgets with her hands. This is probably a form of self-soothing behavior. She waits for another question to which she feels more comfortable responding. I wonder if they had a hard limit on how long this video could be, as Dr. Lehman is moving things along more rapidly than I would in a similar situation. He should, in my opinion, have allowed the pauses to stretch out longer and given Vera more space to talk into. I would also have liked to see Vera given more time to talk about the radio without Dr. Lehman jumping in to ask why. I've interviewed many patients with poverty of thought and increased latency, the delay between being asked a question and answering it. This is common in schizophrenics with formal thought disorder, the severely depressed, the paranoid, and conditions associated with elective or selective mutism. It is important to allow lengthy pauses for these patients. I have sat for 2 or 3 minutes waiting for a severely depressed patient to reply to my asking how they are that morning. As a psychiatrist, it is important not to be afraid of silence and to give people the time they need to get their thoughts out. Recently, I was interviewing an inpatient who was electively mute. I was warned by staff who had previously reviewed her that she might say nothing. I asked my team to time the latency of her replies. I then asked her how she was, and they timed her reply as taking 5.5 minutes. For those 5.5 minutes, I simply sat there, looked calm, didn't glance at my watch or write notes. I maintained reasonable eye contact, not too much, not too little. I made my best effort to non-verbally communicate that I had all the time in the world to wait for a reply. Eventually one came, and we began to make progress. Now, let's continue with our review.
Are you reading or are you thinking?
Reading it.
Verbally, she is giving a negative answer. Instead of saying she is reading or thinking or something else, she opts for the minimal response of denying one of the options given, but volunteering no other information. Paraverbally, there is a lack of intonation, no change in rhythm or rate of speech. Non-verbally, her gaze is averted and her legs are crossed. This signifies that she is willing to remain there, but unwilling to engage fully. Were she signaling a willingness to leave, she would probably place her legs in a position from which she could quickly rise from the chair. She's still giving off change the topic vibes, but Dr. Lehman won't do that. He might stop asking about reading, but he is still going to worry away at just what she spent her time doing. He needs to show this to demonstrate her pathology, and he is a very determined man.
You don't like reading? What are you doing?
This is a nice approach. Dr. Lehman recognizes that she doesn't want to talk about reading, so he phrases his question in a manner which signifies that he's taking reading off the conversational table. He is also changing from a closed-ended question of limited scope, "Do you like reading?" to a more open-ended question, "What do you like doing?" The change in approach is followed by a 4-second pause before Vera answers. Generally, anything longer than a 2-second delay in replying is interpreted negatively by others. Research has shown excessive delays lessen assessment of trustworthiness and competence. In this case, though, we'll give Vera a pass. She is doing well just engaging with what, for her, must be quite an uncomfortable interview.
Music's better. Listening to music and not talking.
You like that?
Bingo. Dr. Lehman's comment is right on 2 levels. The first level is that Vera likes music. The second is that she is much happier with this than his previous question. She demonstrates this by showing improved eye contact of 3 seconds duration and spontaneity, rhythm, and tone of speech. Even the character of her speech has changed. As a psychiatrist, I look for cues like these to highlight difficult areas for patients and to know when I've successfully redirected the conversation to a less difficult topic.
Music is the best, I think.
Vera, you told me another time that sometimes you hear voices talking to you, can't see the people. Does that happen often?
Note how Vera rapidly diverts her gaze very much downwards at talking to you. She doesn't like this topic of discussion, would rather avoid it, and is communicating this very clearly with her eye and head movement.
Yes, I think it's all day.
All day?
Yes, I don't think my head's ever been free of anybody talking.
Can you hear them now?
Since I was a young girl.
While Vera's reply of, "Since I was a young girl," follows very soon after Dr. Lehman asking, "Can you hear them now?" it should be noted that Vera's reply isn't a response to his question. It is a continuation of her previous statement of her head not being free of anybody talking since she was a young girl. Dr. Lehman recognizes this and so asks his question again.
It's quiet now. I can talk, huh? And I can talk without them.
You can talk without whom?
They take away my talking.
The voices?
Yes.
How do they do it?
I don't know.
Note how interested and animated she is relative to previous topics. She has a full 6 seconds of eye contact when stating that they take away my talking. Her tone and rhythm of speech is more animated and varied. Not only her head and face, but also her torso orient towards Dr. Lehman during this time. Her verbal, paraverbal, and non-verbal channels are all aligned to say that this is a topic of interest to her.
Can you tell me what they're saying?
I don't pay any attention to what they say.
This question is difficult for Vera. Note the fleeting eye contact at what, and the immediate diversion of gaze for over 5 seconds. She finds this a difficult topic, either emotionally or in terms of gathering her thoughts about it. Her eye movements are indicative of her thinking about the answer, so I think it is the latter. Her answer is avoidant. It addresses a general topic of voice, but doesn't address the specific question asked. It also is accompanied by a check glance to assess the interviewer's response to this answer. The check glance is seeking to determine if the interviewer is going to be satisfied by this avoidant answer or will push the issue. Note the movement of the hand to the mouth. In such situations, this typically denotes one of two things. Either anxiety, where the mouth-touching behavior is a type of self-soothing behavior to decrease anxiety, or the hand can be a physical barrier to aid in restraining the mouth from saying anything further on the topic. Here I think it is a bit of both, as the voices are clearly distressing to her. Note also that the verbal, paraverbal, and non-verbal channels no longer match. She isn't being fully truthful here. The verbal channel is saying that she pays no attention to them. This implies that they don't impinge upon her thinking or her mood. If this were true, she wouldn't be upset discussing them, or be trying to hold anything back. The paraverbal channel has a false start, which can often indicate uncertainty or untruthfulness. It isn't clear which it is, so we should be careful to avoid putting too much stock into it right now. The nonverbal channel appears, to me, to be very clearly signaling that there's more to be said, but Vera doesn't want to say it. She is almost physically preventing her mouth from betraying her.
But you understand them.
Well, if there was any doubt about it at all, the 8-second pause and very direct gaze into the camera, followed by even greater turning of the gaze, head, and torso away from the interviewer, says it all. She does not want this topic to be explored further. Dr. Lehman picks up on this. Realizing he has pushed this topic as far as he can for now, he switches topics immediately.
Why did you come here, Vera?
Must have been sick.
Are you still sick?
No, I'm much better now.
But you like staying here.
This is very sad. Firstly, she clearly isn't all that much better. Secondly, the 5-second delay in answering the question speaks volumes about how she feels about staying in the hospital. To be clear, it isn't that she is acting as though she is being mistreated or anything like that. But a 5-second pause without answering isn't exactly a ringing endorsement. Imagine how you'd feel if you asked a loved one if they were happy with you, and they said nothing for 5 seconds and then changed the topic. I'm sure most of us would draw the conclusion that something was very, very wrong.
Have you seen your family lately?
No, I haven't.
But aren't you feeling lonesome?
Yes, I was wishing I had a visitor.
I was wishing is a very passive past tense way of saying this. It isn't a very forceful expression, but I think the gaze at the camera says it all.
They haven't seen you for a long time?
No,
Have you written them?
no, I haven't. I don't like writing letters.
Vera is talking about being lonely, the lack of family visits and letters, and describing a really heartbreaking level of disengagement between herself and her family. And yet, she shows a big smile lasting for 2 seconds while talking about this. Her verbal and paraverbal communications are congruent, but her non-verbal communication, the smile, is completely incongruent. In psychiatry, we call this affective incongruity, and it means that your facial expression doesn't match the content of your speech.
Did they write you?
No, I haven't received any letters either.
This is so sad. In the past, individuals with severe and enduring psychiatric illness frequently found themselves moved from acute psychiatric care into residential long-term care. At the time, that often meant asylums. They often stayed there for the rest of their lives. There are many problems with the care in the community models for those with severe, enduring psychiatric illness, particularly around resourcing them properly. It is, however, incontestably superior to the asylum model for the vast majority of patients and helps maintain the social connections so important to all of us.
Think you might have a visit soon?
Possibly if I'm good.
There's genuine, congruent emotionality here. This is effectively congruent, albeit that it is very sad to hear her linking good behavior with visits. She should be visited because her family care for her, not as a reward for good behavior. I'm sure the hospital wasn't preventing visits. It was most likely a family choice. Before we condemn the family too much, we must remember that they were products of their society and time. It was common to have very little family contact with those in long-term residential care back in the 1950s and 60s. It is hard not to feel your heart go out to Vera when she says this, and to reflect on how blighted and limited her life was by dint of her psychiatric illness. Thankfully, we have much better holistic treatments now.
You know what day it is today?
Thursday.
You know what time it is about?
After 12.
That's quite right. 10 minutes past 12. Did you see the paper today?
No, I haven't.
Why not?
The brevity and concreteness of the answer, and the lack of elaboration or curiosity, are all common in simple schizophrenia. Most people would, when asked if they had seen the paper today, ask if there was something interesting in it, assuming that the questioner was asking because of an interesting article. Vera's answer is perfectly correct as far as it goes, but it doesn't go very far.
Don't like reading?
I like magazines. I hate magazines.
Vera shakes her head, speaks, and then drops her head. This is followed by 9 seconds of silence and yet another effectively incongruous smile, which she appears to try to hide by lowering her head further.
My head up there?
Hmm?
Is my head up there?
What
My head
head?
goes up there when I'm quiet.
Where's it going?
Right off.
Where's your head going?
This is the most confusing part of the interview. It isn't quite clear what Vera is talking about, and the cut means we'll never know. Next, Dr. Lehman is seeking to demonstrate the lack of drive. Those with simple schizophrenia tend to have a small number of activities they enjoy and will, if left to their own devices, be perfectly happy doing nothing but those activities for the rest of their life. In this case, Vera would enjoy playing the piano daily today, tomorrow, next year, and in 30 years' time. It would not be a distressing or difficult existence, but quite a limited, apathetic one, surviving rather than living.
What would you like to do now, Vera?
I was playing the piano. I was enjoying playing the piano for a few moments.
And afterwards, what are you going to do next year?
I'd like to play the piano next year.
And now Dr. Lehman makes the scope of the possible even larger. Instead of the possibility of doing something other than the normal daily grind next year, what would Vera do with $100,000? This is the equivalent to about $1 million today. The answer is nothing much, except securing her future in the hospital. This is highly apathetic. Note also the lack of reaction to even the concept of having that much money. If you posit this to people, most will have some evidence of a pleasant mental fantasy while they consider what to do with such a pile of cash.
Well, let's suppose, just for a minute, that you would have $100,000.
Yeah.
What would you do with it?
Hospital needed it, huh?
The hospital needed it?
Mm-hmm.
You mean you would give it to the hospital?
Probably.
And what would you do?
Expect them to keep me, huh?
To make you to keep you here?
Yeah.
Because you like it here. How do you feel?
I'm feeling better, thank you.
Feeling better? Are you sleeping well?
Yes, I'm sleeping better now.
How's your appetite? You must be feeling very lonesome, being alone so long. Are you?
Yes, I was lonely, yes.
Why are you smiling?
It is interesting to see Vera using the past tense defensively again. When asked if she is lonely, she admits she was lonely. This avoids addressing the current situation. It is a common and subtle tactic many people use to appear to be giving a fulsome answer, whilst actually avoiding the question almost entirely. Then Vera again smiles incongruously, and immediately lowers her head and brings her hand up to her mouth in a concealing gesture. Very frequently, those with affective incongruity, secondary to a severe, enduring psychiatric illness, will have had others comment on their affective incongruity before, and so will have formed the habit of hiding it. Again, Vera doesn't answer the question asked.
Have you any friends here?
Yes, I have friends here.
Are you seeing them every day?
Yes, I think so.
And what do? You talk to them?
When I'm allowed to, yes.
You're always allowed to, you know.
Oh, yes.
And what would you like to do now?
Probably it's time to go back for lunch, huh?
You just had your lunch, huh? How long ago?
Half an hour.
Half an hour. Are you hungry again?
No.
Well, let's go anyway. Perhaps we get a cup of coffee.
Yes?
This is a nice way to finish the interview. This has been stressful for Vera, and a nice cup of coffee with Dr. Lehman will be both a good way for her to unwind with some familiar activity and also a good way for Dr. Lehman to check she isn't distressed by the interview. It is also simply a good opportunity to help Vera habituate to and practice a very normal social interaction, having coffee with.
All right.
What will we do?
Note how Vera was excited about getting the coffee. She uncrossed her legs and shifted her weight into a position ready to get out of the chair, but didn't initiate the action, despite being given tacit permission to do so. She only initiated the movement to get up a split second after Dr. Lehman began standing up. This is another example of the aimlessness and apathy so common in simple schizophrenia.
You have seen in this patient apathy, indifference, inappropriate emotional reaction. She was smiling when asked about loneliness, general gracelessness of posture, total lack of ambition and initiative, with no real plans for the future, hallucinations, but her memory and orientation are intact, and she was quite coherent. A characteristic picture of chronic simple schizophrenia.
While this wasn't a diagnostic interview, if we look at the ICD-10 diagnostic criteria, we can see the following. Significant and consistent change for at least 1 year. It has actually been 10 years, of all three of the following. A change in the quality of personal behavior with loss of drive, interests, social withdrawal, and a certain idle aimlessness. B, negative symptoms of apathy, paucity of speech, poor nonverbal communication, blunted affect, and lack of initiative. C, marked decline in social functioning. While it would have been ideal to more fully explore even these symptoms, and to explore those which weren't touched on, we can see sufficient evidence already to say that unfortunately, Vera most probably suffered from simple schizophrenia. I hope you found the explanation of this vintage psychiatric interview interesting and learned a little about simple schizophrenia. I've included relevant references in the description below. I've included links to a book which deals with schizophrenia and psychopathology in general. This is an affiliate link, so if you purchase through it, I'll receive a commission which I'll put towards creating more and better content. Please leave any comments or questions in the comments section, and I'll do my best to answer them. As always, take care of yourselves and each other.